Chennai Declaration is a position statement from medical societies in India and other important stakeholders. We prepared the Chennai Declaration in 2012 and released in 2013. It's a document and an initiative. Our aim was to convince various stakeholders how important antimicrobial resistance is. And after publication of the document, we communicated with the government and all the other stakeholders to take them on board so that we can initiate serious action at national level. And the Chennai Declaration document was studied by the Union Health Ministry formally. We had multiple meetings with the senior officials and then multiple meetings with the various medical societies in their society meetings, and we could convince the media, we could convince other stakeholders. So Chennai Declaration, that's the main one good thing Chennai Declaration has done. It convinced the stakeholders, especially the government, how important antimicrobial resistance is, how serious the issue is, and we need to initiate action.
What has happened since then?
After Chennai Declaration, there were multiple stakeholders. All stakeholders came together, and then Union Health Ministry became more serious on the issue, and at national level we saw more action. At medical society level we saw more action. It's not just the Chennai Declaration. There are other similar initiatives in the country. There are other similar initiatives across the world. So it's a collective work, it's a collective action. No single initiative can convince all stakeholders on such an important issue with the global implications. It should be collective action. So collective action of various initiatives, non-governmental organizations, governmental organizations, and big organizations like World Health Organization, United Nations, and collective action of various countries and all the stakeholders brought up the AMR topic to the international arena. And then various countries started acting much more sincere way. It's a real collective action. In 2015, the World Health Organization released the Global AMR Action Plan. As per that action plan, all countries should formulate national action plan by 2017. 194 countries had signed the Global Action Plan. Then in 2016, the United Nations meeting, there was an important discussion on AMR by the world leaders, and a press release after that, and a resolution on AMR after that. Now 2017, India prepared the National Action Plan, and we instructed all the states to formulate state action plan. But so far, only 2 states have formulated state action plan. Kerala last year and Madhya Pradesh 2 weeks ago. Now today we have 28 states and 9 union territories. So out of these 28 states and 9 union territories, only 2 have released the state action plan. That's 2 years after we prepared the national action plan. In the global level, similar way, some countries prepared the national action plan, some countries haven't even prepared the national action plan. And many of these countries prepared the national action plans, haven't really started implementing it sincere way. So at a global level and national level, it's limited success. I won't say it failure, it's never a failure. So far we have achieved a lot, but that is limited success. We have a long way to go, and we need that long way to go. At national level, we need all states to formulate state action plan, and then implementation is an Himalayan task. I'm talking about the simple process of formulating a state action plan. So in India, when we talk about, yes, there's a lot of awareness among all stakeholders. Every day there are discussions in some part of the country on AMR, but that hasn't reflected to the ground level state action plan and the real process of implementation at the government level, the state level. At national level, yes, we have got national action plan and national guideline, national infection control guideline, and we recently banned the colistin, lot of initiatives by the union government. But India, health is predominantly a state topic. States have to act. So we need to bring states on board. For that we need more coordination from the union ministry. Union ministry is doing a good job, but we need now to, to inspire to all the states to formulate the state action plan and implement. Then only at national level we can succeed in containing AMR, at least to some extent. Out of 75,000 hospitals in India, only 500 are NABH accredited. And once NABH accredited, there is some way of monitoring infection control standards and antibody stewardship standards. So all these hospitals have got some basic minimum levels of antibody stewardship and infection control protocol. We don't even know the status of the majority of hospitals in the country. How to monitor? There is no national level monitoring mechanism. We have got two network of national surveillance, one by the NCDC, there's a government organization, and then the ICMR. Two network has got 24 hospitals each in a country with 75,000 hospitals. We need at least a national network of 500 hospitals, at least 200 hospitals, where we can monitor the resistance pattern. We know the antibiogram, and we know we can monitor how well it's working. So, but one good point, even experts including myself always thought antibiotic stewardship is a core component of the controlling AMR. That was a concept we had till probably 5 years ago, and that concept is changing. Yes, we all agree that irrational antibody usage creates antibody resistance. But when we talk about controlling antibody usage in developing countries, sanitation is much more important. Sanitation in the community, hygiene standards in the hospitals are much more important than antibiotic stewardship. And this is now proven in various scientific publications. The situation is different in the developed world because they don't have serious sanitation issue in the hospital, they don't have a serious sanitation issue in the community. In a developing country like India, if you ask me what should be the most important component of tackling AMR at national level, my answer will be improving sanitation in the community, improving the cleanliness standards of Indian hospitals, only infection control standards. Only then, in my opinion, antibody stewardship play a role. Nobody questions the importance of antibody stewardship. Yes, antibody usage creates a resistance and maintains a resistance. But in a country like India where the resistance is already at a very high level, when we talk about antibody stewardship, when we talk about surveillance alone, we are missing the big elephant of sanitation and the cleanliness. Antimicrobial resistance. Many principles of antibiotic resistance hold good for anti-TB drug resistance as well. Irrational usage, overprescription of TB drug, underutilization of TB drugs creates TB drug resistance. Poverty spreads TB. Just like antibody resistance, sanitation spreads superbugs. Super TB bugs are spread through inadequate hygiene, inadequate sanitation, and poverty. The basic cause of antimicrobial drug resistance is poverty, lack of governance, lack of infrastructure. That's why antimicrobial resistance is not a scientific topic, it's a socio-political topic. Whether it is antibody resistance or anti-TB drug resistance, if you want to control this problem, we need to rope in the public, politicians, media, not just medical community. Whether antibody resistance or anti-TB resistance, we concentrate a lot of our work among medical community. In my opinion, we need public, politicians, media, policymakers. They are much more important than the medical community. We need to educate the public, educate the mass, and convince the politicians, convince opinion makers. Conventionally in India, the medical curriculum doesn't give any importance to antimicrobial resistance or even to antibiotic usage. Our medical curriculum so far has been quite old-fashioned, giving a lot of importance to conventional clinical examination methodologies, which has got no relevance in the daily clinical practice, and we forego to teach our undergraduates and postgraduates on antibiotic usage. And majority of the patients coming to a general physician in India are coming with infectious disease, and we forgot this big spectrum of infectious diseases in our curricula and in our undergraduate and postgraduate medical examination. That has to change. Now with NMC in picture, if we convince the ministry and other stakeholders, we will be able to make that change. We need every year medical student, first year to final year medical student and postgraduate student should have structured curriculum on infectious diseases and antibiotic usage, including anti-TB and other anti-infective usage. How to use in the practical world. Our curriculum should be more practical to the real world than copying the Western textbooks and Western curricula.